Hi, good evening, guys. So I'm Fun Leon. Welcome to the 10th episode of Meet the Specialist series, and we'll talk about the emergency medicine today with Dr. Hafiz. So thank you guys for sparing your time to join here because from what I know, there's actually 3 events going on at the same time, and I saw there's 15 people here, which is quite nice. So thank you guys for joining this session and let us know more about emergency medicine lah. So I'm Fun Leon, the third year medical student, and also the committee for medical society for this term. Then and the moderator for today, or the host lah. So nice to meet all of you, and let's have an enjoyable session with Dr. Hafiz. So I would like to remind everyone that this is actually a Facebook Live. Yep. So if there's any questions that you would like to ask, like Dr. Hafiz or ask me, then you can just type it in the comment sections in the chat box. Then after this session, around 9:35 like that, we will be providing a feedback form, and you guys can give us feedback on how we did on our session today. And as well as you can subscribe to our mail and follow MEDSOC social media while waiting. So we have a lot of time for that. So you can see we have Facebook, Medical Society. You can like our Facebook page. Then for Instagram, we have MEDSOC_UM. You can follow our Instagram page. And as well as to scan this QR code to subscribe to our mailing list, where you can get a lot of updates and newsletter from MEDSOC itself. A lot of stuff that's going on. Okay, so I would like to introduce Dr. Hafiz first before he comes in. Dr. Hafyzuddin Muhammad Yusuf is actually a medical lecturer from the Academic Unit of Trauma and Emergency. He graduated from Royal College of Surgeons Ireland in 2010, completed Masters in Emergency Medicine in 2019 under the Trainee Lecturer Program in University of Malaya. His interests include emergency cardiac care and also pediatrics emergency medicine. He actually likes running and wanted to complete a marathon by this year, but we have MCO, so then he was a speaker for breakfast at Health on aerosol box, which is quite an interesting topic. And he was awarded the second best clinical lecturer in Faculty of Medicine Yeah, so he's actually quite the star among us in FOM lah. So with the spotlight on emergency physicians due to their nature as true frontliners during the COVID-19 pandemic, actually I'm really curious to find out how is the life of a physician, emergency physician is like. So there will be about 4 sections talking about different topics, including why did you choose emergency medicine, what does an emergency physician do, pathway, and also work-life balance. So without ado, let us start our session by asking Dr. Hafiz our first question. But before that, let us invite Dr. Hafiz here. So good evening, Dr. Hafiz. Nice to meet you here.
Hi, Assalamualaikum. Very good evening. Sorry, I think just now what you say, second, that's not me second as a... No, there's the clinical department, the emergency department. No, not clinical lecturer, is a clinical department that has the award. Yeah.
But it's still good lah. It's still outstanding, doctor.
Yeah.
So, doctor. So, can I ask you just the first question? Okay. Or do you mind to introduce yourself in your own way first, doctor?
Okay, Assalamualaikum and very good evening. My name is Mohd Hafyzuddin bin Mak Yusuf. I was born in Seremban, upbringing in Petaling Jaya, just beside University Hospital. And I went to study in Regular Surgeon, been in the houseman in HUKM, Batu Pahat Hospital as a MO, and then I joined PPM as a MO, emergency, and now I'm the medical lecturer in emergency. Yeah, and I like to play badminton as well at the same time.
So seems like Doctor really active and seems like a smooth pathway from doctor into emergency medicine. All of it is so well. So doctor, can I ask you like so for the first question, doctor, why is it your why did you choose emergency medicine? Is there any passion behind it?
Okay, should I start sharing the slideshow or I just
Yeah, doctor, you can start to share the slideshow and let us see like everything.
Okay, sure. Let me share the screen.
Yeah, doctor, we can see your slide. Yeah.
Okay, perfect. So the question, before I go to the first question, I would like to say thank you again to MEDSOC for inviting me as a guest speaker. And this topic as meet the specialist, I think it should, I will be seeing that meet the team of specialists because the emergency medicine, they need a lot of team members to work as a team. So, usually before I start my daily living life as a working as an emergency, I will check the outside windows, see the sunshine, see what happening. And then of course, definitely you need to have your breakfast. The first day is a breakfast, okay? So this is where my workplace after I graduated as an EP. Before that, is all on the floor, okay? So you need to have a coffee of every day because you need energy. And this last year exercise during the MCO, the first one, for so that you be very active and to prevent burnout. Okay, so why I do emergency medicine? Okay, what I choose, these are my photos of my housemanship. I was in HUKM, and the first that that's during my first posting, I do emergency medicine where I have learned a lot, and it seems that the lecturer, the team member, the nursing, the paramedic teach me a lot of things. And I remember that's the first time that I do take history examination and do my own treatment. Because before this, previously as a first, second posting, usually you just follow and you don't have independent. You're not independent. And I remember during my posting emergency, there's one case that we have witness arrest. A few minutes, patient collapsed in front of the emergency, and we do CPR. The patient is about 60, 70 years old. And after, I remember I was CPR, and then the paramedic, the registrar asked the paramedic to intubate. So during that time as a housemanship, I feel like, oh, I missed the chance to intubate the patient. And after a few minutes, then suddenly the registrar asked me, okay, Hafiz, please shock the patient. So defibrillation. That's the first time that I defibrillation. And you know what? I defibrillate, shock the patient more than 10 times because the persistent VF, VT, and luckily patient has RSC and sent to cath lab. Okay, but I'm not sure whether patient regain conscious as no. But it's really, I remember that. And then the registrar teach me about the ATLS, advanced trauma life support, primary survey, secondary survey. Until now, I still remember it, and that's where I start my journey as emergency medicine doctor.
Yeah, I can see that doctors really passionate about like all this emergency medicine. You get to learn like from groundwork up, from history taking, physical examination, investigations, management, and so on. individually and also directly, and you get to have like the first touch on everything, which is why doctors, since you're in the during you're in the houseman, then you have the passion to join emergency medicine. Yeah.
Yes.
So, doctor, I think you can start with the history of emergency medicine that was on your first few slides.
I restart again, yeah? Okay.
Yeah.
Okay, then, so do you remember this, where it started, the emergency medicine, where the Highland Towers collapsed in 1993? And that's the time where it seems that Malaysia has no proper disaster team, and they need to ask from the Japan and Germans with the tactical team for the disaster. So after that, it's realized that 1993, this Prof. Datuk Setiak Abu Hassan is a orthopedic training, and then they start reforming the emergency department. And Dr. Sabara is anesthetic, and Dr. Azhar, not sure. John also changed. I think there's no more training emergency yet in Malaysia. And 1998, they started the first emergency medicine program in the USM. And 2002, after 4 years, has 6 emergency physician produced. The first, right? One of it is a Prof. Rashidi, our UM lecturer. Okay, and then Young is about 33 decades already since the incidents. And that's I already say why I'm emergency. Initially, I went to Hospital Batu Pahat as a MO after my housemanship. I request to do emergency, but that time is full. So I joined the anesthetic for a while. I learned, and I scout. I heard that my friends in University Hospital did emergency. So I tried to apply, and alhamdulillah, I managed to get the emergency as a MO there in here. Okay, then so remember, it's teamwork makes the dream work. So all needed you cannot work alone in emergency. The nurse, the paramedic, the houseman, and all the lecturer. I really thank to all that have teach me and support me, right? And these are latest that we take photos during this time. So this is where we have new teams, Dr. Alia, our latest young lecturer, and all Dr. Aida, Dr. Muhammad, HOD, Dr. Kat. So that's why Dr. Afiq, Dr. Hafyzuddin, Dr. Zul, that's why I say is meet the team of specialists. So all of them really has their specialty, and if anything that I have problem, definitely I need to talk to them. Okay, because is so much the thing that you want to learn about emergency is too many. So you have the framework, but sometimes there's a specialty that you need to discuss, and because there's a lot of cognitive overload, so hence you need to have a lot of people beside around you. Sometimes the nurse also teach you, and the paramedic also give some input. So I give the definition. You can see there's a lot of words. Definitely you cannot focus. Okay, this is the definition of emergency. This is how emergency is. There's a lot of words, but you need to focus targeted history, and manage the patient. What the most important thing. So this is how you need to extract the point. So emergency is a diagnosis of and treatment of unforeseen illness. So you don't know, it's undifferentiated. So you want to evaluate diagnosis and treatment. Okay, and expeditious treatment, whether you need to do surgical, medical treatment, admit as soon as possible. Okay, it's also need to plan, oversight, and disaster preparedness. So luckily during the pandemic COVID-19, we have MERS-CoV algorithm, the SOP. So we utilize the MERS-CoV first. After that, it become COVID. So Dr. Afiq and a lot of lecturers become the pioneer of the COVID-19 task force. Okay, in emergency physician in United States, there is a patient safety net, because in fact in emergency, if you wrong diagnosis, the first impression sometimes patient, for example, complain of sore throats. So maybe it's something like atypical presentation, suddenly patient can collapse. That's what happened actually. One day that ECG looked quite normal, and then the patient has an atypical presentation, and then suddenly patient collapsed. while waiting because of the triaging. So that's it's very important that you can do diagnosis properly and assess properly initially. Okay, and so in International Federation of Emergency Medicine is a knowledge and skill of prevention, diagnosis, management of acute and urgent illness and injury. It's undifferentiated. You can stand by there, you're waiting, whether it's mild, moderate, severe, urgent, non-urgent. So everything is there, 24 hours, 7 days per week. Okay, never stop. The emergency cannot be PKP, like it's always there. Okay, and it's either pre-hospital, the ambulance, so it's always ongoing. So for me, the definition is emergency medicine is a J of all trades, but it's a gatekeeper for the hospital and is master of the triaging, is a disaster master, pre-hospital, AOA, toxicology, acute care, trauma, OSCC, for example, the scan, because OSCC, for example, patient has abuse, sexual abuse. So if you patient may initially maybe complain something injury, but actually it's a domestic violence, or if you have that instinct or you have proper history taking, you got good relationship with the patient, good communication, so sometimes they can reveal. So you miss the diagnosis, for example, a kid that come many times to the hospital because of the injury, then suddenly you didn't notice it's a accidental injury, it's an abuse, so some patient can come up with a body after that, after a few days, yeah, if you, because of multiple abuse. The last time maybe is a little damage. So as I say, it's you need to be very good in emergency, the triaging. There's a primary triaging, okay, and a secondary triaging. So it's very important. Person that's in the middle is the person that in the video just now, Bilal. He also is a very active person. Okay. So as a care of duty of emergency and doctors, of course, I always remind students, and is taught by my senior lecturer last time. Always you have diagnosis, evaluate clinically properly, and then diagnosis, fast diagnosis, rapid diagnosis, and treatment based on diagnosis, and prognosis. Prognosis means that whether the patient able to discharge home or need admission or need ICU admission. And as an emergency physician, you need to refine the define. So means that you have defined the diagnosis, you need to refine it more accurately, whether, for example, metabolic acidosis, whether it's severe, mild, moderate, or whether it's with the respiratory compensation. Okay, for example, shock, whether decompensated shock, compensated shock, okay, and also whether it's what type of shock. So because if you wrong diagnosis, it can have a detrimental to the patient. So okay, this is a day of day today of the emergency doctor as MO. Initially, you're always in standby mode. All right, and you started with passover, and then sometimes there's a teaching on the bedside. This is before the COVID, so it's difficult to have large group in teaching. And then after you pass over, you review the patient and continuation of care. And if there's a new patient, you need to get a very fast targeted history, physical examination, investigation, diagnosis, treatment, and dispose, because patient can come non-stop until you have no bed. And the fact is overcrowding, and that can disturb your management. And also, and then now we have like maximum capacity alert for the emergency, just to alert other department. And then after that, you pass over, and then you can rest after that. Okay. And then the challenges. Okay, Leong, you have any question, or shall I continue?
Doctor, I think you can continue first. If there's any questions, they will just ask in the chat box.
Okay, definitely the emergency, there's challenges. It's a 24/7 service, never stop. So usually there's a challenge in as this is a kind of disaster management, staff, space, system. So staff, usually if let's say many patient at one go, then the staff has EL, emergency leave, MC, so you can lack of resources. However, currently, because we have expand our emergency to many places, for example, on the right side, let me try this one. Okay, for on the right side, there's actually fracture room. Sorry, fracture room that become our resource area. Initially, resource area in the red zone, but now it's become we expanded to the fracture room. Okay, and that's how we expand our space. And that's in front of it is our camera for COVID-10. Before the pandemic, there's no tent. We were parking the car there. Then suddenly cannot park, and there's a tent for sobbing for quarantine space. Yeah, and the staff, and also the system, the shift system. Some people like to shift because you can have morning. If you work morning, you have finish early at 3 p.m. If you work PM, you can do a lot of works in the morning. However, sometimes the shift system, and also if you work at night, 10 o'clock, you can go home at 8 in the morning. So you don't have to over 24 hours or more than that, like on-call system. Okay, but once you become specialist, you become cover longer time because you not standby on the floor, but you more on-call. You do rounds, and then you if the patient is settled, you can go other place to cover. Right. So the challenge is the overcrowding. If more patient, you don't know. Hopefully, I remember one patient severe asthma only on the wheelchair. So luckily we settle the bronchospasm. No need to speak out on the chair or on the floor. So if maybe we prepare for canvas like the hospital, the military hospital. Okay, and then the challenge is because patient came shortness of breath, but many diagnosis of shortness of breath. I remember when I was anesthetic, everything is diagnosis is there. Okay, and but currently, if patient come, you need to make sure you do not do any wrong diagnosis, and also you did not miss the life-threatening diagnosis. And then sometimes the patient can be verbally, patient or family can be verbally abused because of they need to wait. But currently, I think because of the MCO and also the SOP, I think it should be less because they cannot go into the patient area, the treatment area, and more control. The environment is more control for the family members because patient usually is ill, cannot unless is toxicated with for example alcohol or restless, so they can be combative. But it is because organic causes. But it's because if let's say that one you need to control physically and also pharmacologically. But if let's say family members can be, if let's say in green zone, currently green zone is closed, no non-critical case. So you used to have waiting for 2-3 hours because of the influx of patient at night. Okay, and one thing about if you have the wrong diagnosis initially, it can be anchoring bias. It's kind of once you because you're the first person, you're the frontliner, the front door, the gatekeeper. You once you say is ACS, and then the other person may follow the other doctors, and also the primary team may follow as well. If you say the ECG is normal, maybe they say everything is say normal, and once there's something wrong, then we reflex back, and maybe there's a bias because you just follow you just bias with the previous diagnosis. So there's a danger bit. So why is emergency very satisfactory is because you diagnose a lot of patient, and the therapeutic is what we call you treat patient like acute pulmonary edema, very tachypneic, and then when you give the non-invasive ventilation, you give control the blood pressure, afterload, preload, suddenly patient like few hours can talk to you after that. And for example, the patient with severe asthma cannot speak unless suddenly after a few naps, and after you're giving all the magnesium sulfate, bronchodilation, so it can restore the breathing pattern as after that. So it's 24 hours only the place that patient and family can turn. So emergency is something that perception of the patient is not, if we think it's not critical, but the family, the patient think is danger to them. So that's why they come to emergency. Okay. So they fulfill the ideas of the medicine. Why you are ideals? Because you save life, prevent deterioration, relieve suffering, and do no harm. That's our bioethics. Save life. Yeah, do the best. And sometimes currently the shift work can be flexible. You can control your hours. Okay. Okay. This is one of the BMJ paper. They said during if you're a medical student, you are crazy. Hopefully, crazy working hard. I mean, okay. And your attention, they said, is non-existent. So emergency is very fast, quick, short attention span. If you do one patient 1 hour, maybe it's like psychiatric or different department, because we need to quickly, rapidly diagnose and treatment, and we need to settle all the acute problem. And then after that, follow with the long-term plan. Okay. So definitely you're the advocate of the patient. Sometimes there's no one want to take the patient. So you need to really push you until you make the decision. Because family, for example, I remember my previous on-call, I think 2 days ago, polytrauma. So patient has no family members. So you need to be the advocate. You mean you need to sign for the CT scan. You need to do the best, because if let's say patient, you don't know comorbid, everything, you don't give the non-active resuscitation. You just give, you intubate, you stabilize patient, you save life. And after that, if let's say nobody want to take, you must push them to take in, whether, because we know that sometimes the operation can be very life threatening, but if you don't do the operation, then still is no hope. So we need to always ask for the best benefit of the patient. Okay, so I remember during my houseman, the director says, Clark like a detective, present like a lawyer, treat like a doctor. So you must advocate your patient and treat a doctor. And out of probability, sign of uncertainty. This is William Osler says, where everything in emergency is not 100%. So you do the targeted history and physical examination, and the most probability is the one that you treat. Maybe 80%, 70%, 80%, 90%. You can't get 100% unless you do confirmation, diagnostic of confirmation. For example, the COVID, right? So PCR is the best, or biofire is PCR, RT-PCR, but it takes time. So for RTK, it's only maybe half an hour, less than half an hour, so you can get positive, negative. So, but it's less probability, it's less sensitive. So, but we still take it as a positive because you want to think of worst case scenario. So PCR is almost 100%, but it takes few hours. So that's why we need to treat immediately and this plan admission as soon as possible, right? So there's a comparison. So you have a lot of range, low, moderate, high acuity. About 10%, remember, patient will be need admission, and differentiated patient, no prior rapport, you don't know who's coming, okay? And most diagnostic studies are urgent and emergent. It's not scheduled. It's always open, so you stand by. Okay, result of diagnostic studies available within. Okay, so just to help of that cognitive overload, you have the clinical decision making, event driven, where you learn about primary survey, A, B, C, D. Airway first, airway, assess airway, treat airway. Assess breathing, treat breathing. Okay. And circulation, assess circulation, treat circulation. Algorithm, where you learn ACLS, ATLS. It's just to help you that whether patient unstable, stable, and then complex, whether there's a pulse or no pulse, VF, VT, pulseless, shockable rhythm. So this all algorithm is just to make it easy to in the emergency in the critical time. Okay, And also you remember another decision is how you need to rule out worst case scenario, at least 5 diagnosis, chest pain, whereas ACS, aortic dissection, okay. Pattern recognition is usually more like experience. You see the patient, oh, there's a pattern, means that, for example, Charcot triad, the Charcot triad is the one that jaundice, right? So jaundice,
Yes.
the biliary pain, and also fever. Okay, that's I think Charcot triad. Okay, so there's a pattern. Macam back triad but back triad is for cardiac tamponade, but it's only in the books is rarely see. It's always confirmed with that ultrasound. So back triad is a cardiac tamponade. Muffled heart sounds. There's a pattern recognition, muffled heart sound, JVP raise, and also hypotension. Okay, pattern recognition, for example, you can see patient deform. So you think it's already, like my patient polytrauma, the patient the hip is a different position, so like internal rotated, so assume is posterior dislocation. So that's you see and you diagnose straight. It's a more experience, okay. And hypothetical deductive means that you get 5 diagnoses and you deduct. Just kind of rule out worst case scenario. Okay. So ini is an accident emergency. It's not anything and everything. So there's where I want to share this hospital unit. Dr. Afiq is in charge of the hospital. This is where we see this at the team place. There's a map, there's an ambulance, a video, so we can see what happening. If let's say we dispatch, if any disaster, we can medical direction from there. And this is where we wear the jackets for the paramedic. And if needed for disaster, the doctor need to go there as well. Okay. I just want to share that the specialty need very important ECG skill, because in emergency, patient always come with pain, and one of it is chest pain, abdominal pain. But the chest pain, you need to do ECG, and if you misinterpret ECG, then it's detrimental. So I just want to share this photo of me winning my first iPad, but there's only the picture of the National Acute Myocardial Infarction course 2017. So let's say that I menang iPad lah, but I don't have the photo of taking the iPad. I forgot to take. Anyway, there's the ECG of, I remember do you know what's the Fun Leong, this ECG?
VF.
Okay, this kind of VF is a tosa de poids.
Sorry, tosa de poids, sorry.
Yeah, okay.
Yeah,
right, good. Okay, perfect. There's suddenly there's change. Okay, long QT. So that's important of the CG. All right, a lot of ECG. Okay, we also thanks to other my colleague share this obese patient. When there's obese, there's a difficult airway that we worry of. If you fail airway, definitely you have no oxygenation and you can kill the patient. All right, and this is a critical care that you can do scope and suction of the ETT, kind of a ICU management, just that we cannot one-to-one. Okay, there's a lot of patient. This is where we do research. We have PAPR initially for COVID. We have the box. We do the research, and it seems that the box is difficult and also not improving much. Yeah, the most important thing is your DON and DOF. Okay, DOFing is very important. This was started where you need to MCO1, stay at home. There's a first KEMA there. Okay, there's a doctor, the paramedic, Dr. Khairul sponsor a bit for the tent, not the tent, the barrier. All right. So Dr. Hafyzuddin, okay. And I remember during my on-call last year, suddenly there's the infectious disease, all the team before the SOP all meeting urgently in the bilik bencana. This is a bilik bencana to think about the pandemic, right? So the emergency, and Dr. Nabila also present in the novel coronavirus 2019 before the MCO 2020. Okay, and this is where I present. So this is a daily living. You need to present and you share the knowledge. Okay, this is a research. So as a emergency physician and also medical lecturer, we need to publish for the university to maintain the ranking. And just want to share this up above photo is my okay highlighter. That's a highlight. Oh, sorry. Laser pointer. Okay. This is 2015, about 5 years ago, and after all graduated is 2020. So Dr. Hafiz is a pre-hospitals and also disaster. Dr. Liana is a lot of RCA, possible toxicology. Dr. Bell is a vaccine person emergency. So anything vaccine can ask her for resuscitating in a vaccine, and PPV in University Malaya, PPUM. And Dr. Aizu is a disaster person as well, and also the pre-hospital. Okay, all has advanced training as already starting. So this is where I my class last time during my MO. So you need to work, and after you pass over, before pass over, maybe you need to go for class. Okay, so maybe if there's no patient during your shift, you can skip for a while and join the class. So everything is very packed at the time. So you need to be work. So sometimes if you're off day, if study leave, you can go outside for study. And this is where I want to share the disaster room. Actually, if any disaster happen, bangunan runtuh for like Highland Towers or LRT, for example. Luckily, LRT is quite far. If not, if nearby, we need to dispose. And there's a lot of flash card. This action card. Action card. The director, timbalan pengarah semua all has their action card, so that need to do very fast. So if you're very tired, last time during my MO, I sleep and my colleague took picture. So yeah, it's okay. If you need sleep, you can sleep. As long as no patient need your advice lah. Okay, or you can adjust with the friends. Okay, and also as MO, sometimes you need go to training. It's not only in hospital, university. In KKM also, if you teach students or nursing, you have training. So it's good point. They have a point in the interview, right? And this I want to share. Dr. Hafyzuddin rarely has, because patient no prior contact. Then suddenly you have contact with the patient, and then the patient notice you and celebrate you. So it's very, very good. Okay, because you have no contact, unlike cardiologists or everyone that has a follow-up. So this training before and after, all wearing masks. Okay. So there's remember as you need to train the student as well. Okay, this during my MO, there's a quality improvement. So you not only treat the patient, the definition of emergency medicine is to plan and also improve the system. So that's where we have always quality improvement. I think this is EMA, emergency medical observation unit. So any unit you need to improve any program, and this is where you train outside, because CPR, basic life support, still a lot more to train. Not only you need to train the students, the society, the citizen. And of course, this is where also algorithm, you need to plan the algorithm. Dr. Afiq always has a plan the algorithm to make it easy, because if no black and white, no algorithm, is difficult to whether a patient can be isolated or not isolated, admit where. So it's need to be, because dynamic is very always changes. Patient sekali 10 patient datang sekali, then you have no bed, you need to quickly clear and make it happen. Okay, last year we did the videos for training. There's a PAPR, so we have there's a extra work lah, means that we have a video. Currently we did BLS also. The team members has basic life support video. So this is for donning. Okay. Okay, and then this video. Okay, and then this Dr. Zul and Charlie. That we also need to make sure our equipment is intact, and if not enough, we need to ask from the higher authority, higher pengurusan. So it's important. Like this, a video laryngoscopy. Of course, during the pandemic, you need to scope using the video laryngoscope rather than direct, because you want to distance from the mouth and aerosolized generating procedure. And this is a BLS video that we doing, and this is the last time that we do for the Don doffing. Okay, so this is the next topic. Shall I continue? Fun Leong, any question?
Yeah, wait, doctor, just a bit. There's no questions in the chat box, but there's a few questions for you lah. What is the what the first question is about, like, what does an emergency physician do? What are some traits that actually make a good emergency physician?
What are the traits? Oh, okay.
Yeah, what are the
traits? So, the traits, because it's always adrenaline rush, so you need to have like very healthy and very fast thinking. So means that, but it's not rushing. It's just like my colleague said, Dr. Hafyzuddin said, slow is smooth, smooth is fast. So means that you must have a framework. Means you know, sometimes you anticipate. So it's preparedness. So in disaster, it's always prepared. Preparedness save life. So means that you always prepare. You know, patient always come with a chest pain, or shortness of breath. So you must equip yourself with the basic acute management. And then you know your tools, means that how to use the video laryngoscopy. You need to have you know, your oxygen, the ventilator machine, medication that you have. Different hospital has different, so you need to know your equipment and also your medication. So you prepare yourself, prepare your team members, prepare your, if let's say for example trauma, they call early. Okay, the paramedic they have call the MC, the ambulance say 5 minutes ETA, patient GCS3. So we already know it's already anticipating difficult airway because trauma, and need to intubate because GCS3 must cerebral resuscitation, and you must prepare the blood if hypotension. You must think ahead before patient come. Okay, so that's the trait is anticipation and preparedness. And also you need to have a high energy, because it's very peak, the energy come up, and after that you can rest. If let's say patient come multiple 3-4 times until few hours, so maybe you need to persistently, and after that you rest. Yeah, it can be tiring. You must be very fit, and also you must prepare and anticipate lah. Yep.
So doctor, is it like if you have a fast response and as well as you are really efficient at your work, then it is also like a few traits to be in this specialty?
Yeah, exactly. I was thinking like it's like it's a sports, like kind of a sports, like
I was thinking about
training every time you must be efficient, target. So it means that you always see the patient, you pattern recognition, you know, tactic is faster, your psychomotor, because there's is the more experience, the psychomotor, all the neuron is be related. So it's the more simulation, because that's why sometimes if patient low numbers but high acuity, means that for example PITS trauma is rarely happen, but if happen very very difficult. So you need to have simulation many times, simulation until you are efficient. So that's where the repetition is very important. Yeah.
I see. So another question is about emergency physicians. Is it only concentrated on urban areas, or like in rural areas, rural hospitals, community hospitals, there's less emergency physicians? So what is the availability between that? How many?
Okay. Yeah. Definitely, I think there's a discrepancy because currently the emergency physician is more concentrated in Peninsula. Sebab currently total is about 400. Some in private, some in the Ministry of Defence, some in the University Hospital. So I think there's a lot of more to emergency because currently 400, they target by 5 years is 700. So usually the doctor would like to stay in the emergency in the peninsula. But I think currently the MOH has, I don't know the statistic, but the MOH has the power to make sure once you pass as emergency physician, you'll be put in the district or anywhere needed, so they can send you anywhere. So, but I don't have the statistic. Definitely the MOH has the plan to cater all. Yeah.
I see. So another last question is that how do you think the demographics in terms of like age, race, and gender, like for emergency physicians 10 years ago, what is the difference between there and now? Yeah. Do you notice
can you repeat
any
the question?
difference? So like so what do you think in an emergency physician team? Is there any change in the trends in terms of age, race, and also genders for emergency physicians?
I think currently almost the same. All
Almost.
the man, the woman, maybe the woman more taking the emergency medicine possible. I don't know the statistic, but I think there's a lot more ladies applying for emergency physician, and also all the races is all equal. Yeah, Chinese, India, Malay, and also the age also is, I think, because of the after 2 years of MO, and then also you need to interview, the age is almost the same, but 30 plus. Yeah.
I see. Yeah, thank you, doctor, for answering the question. Yeah, we can continue with this postgraduate program for the pathway.
I would like to thank. Okay, thank you very much. I would like to thank Dr. Shamsu from HUKM and also Prof. Associate Prof. Shefarid for sharing the slideshow. They are the experts in the conjoint board of emergency medicine. So in emergency, there's a conjoint board where you have Ministry of Health, University Malaya, UKM, USM, and you also your ITM currently to decide. So you need last time is usually 3 university, UKM, USM, then UM. The first is USM, and then UKM, and also followed by UM. Currently, UITM will be starting their master training this year. So who can apply? The KKM, the Ministry of Health trainees with HLP. So hadiah latihan persekutuan is currently a bit difficult because only the confirm or permanent can get it. Currently, a lot of contracts, so they're still discussing about that. And international applicants, we have finally currently one from Arab Saudi international, and last time from Sudan. Okay, and university trainees like me can apply, and Minister of Defence also can apply. So private candidate actually can also apply actually, but need to all pay. So hadiah latihan persekutuan, you guys can check it, there are a lot of syarat permohonan for always for the KKM lah, for Kementerian Kesihatan. Alright, so basically there's 4 university, and you can universities usually is either you in campus, out campus, or total out campus, or total in campus. For example, 4 years minimum. If let's say you do in campus, you finish 4 years in either university, USM, UKM, or UM. And if you fail, you can maximum up to 7 years max. All right. Some out campus, you do 2 years in university, 2 years at the Kementerian Kesihatan. And currently there's a total of 4 years in MOH hospital. There's few master student that cannot only do 4 years in MOH, didn't join the university posting. Okay, so you can join after your housemanship. You can practice usually 1 year of experience as in ED emergency MO and 1 year in acute care. Right, for example, NS or critical care. So you need to have full MMC and also qualification. So selection. So here, where I'm become the part of the secretariat, online interview lah. So you have for you emergency medicine, you have universal scoring for selection of emergency medicine trainee, USMED. So the MEDEX is the medical specialist and pre-entry examination is conducted by the Majlis Pendidikan Malaysia. So once a year, RM800 per paper, valid for 3 years. This is only for emergency MEDEX. If let's say you want to join NS, different paper. So if you take 2 papers, you need to pay about 1,600. So it's a true false, 60 questions. Okay, so it's total about 40%. It's a lot of points. And then after that, 30% of it is a service and scholarly work. So this is the first time this year we did this. If you work in Sabah Sarawak, you have few percent, extra 2%. Previous application, so some repeating their application. Sometimes during the interview, they say, is it first time that you apply? No, this is second time. So there's maybe extra point. And then how many years you working, and also the academic training. This is what I say training. So you need to be part of the basic life support trainer or some training so that you have some point extra for compared to other candidate. So I need to work very hard. Scholarly work, this is where you put a poster in conference or you can publish during your housemanship, for example. During our research, the Orisa box, there's a houseman that joined us and he published together with us. So he has a few percentage. And life support, this is quite easy. You just paid for the ACLS, ATLS or any course. And co-curriculum, this, for example, you become secretariat or you could also virtual running, any exercise or it's just an extra activity that you can show that you can add on to your marks. And during the interview, interview online is 20%. And at the same time, you'll be asking for presentation that recorded and sent to the evaluator. So that is offline, but you send the PowerPoint. Okay, so total is about 100%. The exam, your scholarly work, your topic presentation that you recorded, and online interview. Okay. The curriculum is all the critical acute care, the anesthesis, emergency, cardiology, surgery, pediatric, orthopedic, right, and ONG. So this to train your brain, to train your hands, and to train your heart, right? So it's cognitive, affective, psychomotor. So the exam is formative, summative. Formative is yearly where you has a posting assessment year end. If let's say you're not up to par, maybe you're being advised or being extended, for example. And dissertation is very important before you take your final exam. So part 1 is a lot of basic science. It's first year, and of first year exam. Once you pass, you can go to second year. And part 2 exam is at your final year, fourth year. But in order to go for the exam, you need to complete your dissertation or your thesis, right? This is my photo during my exam final year at HUKM. So how I start houseman at HUKM, now I've finished as master in HUKM, but UM still in my head lah. UM is number 1, right? Okay, so parallel pathway emergency medicine. So this from the Royal College of Emergency. Prof. Shefari is currently the head of conjoint board of emergency medicine. So it started about 5 years ago because the requirement currently about 400 plus EP, emergency physician, and our country need 700 in another 4-5 years, and in 10 years about 1,000. So they need to increase the numbers. Okay, this briefly, there's changes of name, MRCM, part A, B, C. Then after that, they become primary, intermediate, and OSCE. Then after that, on August, they become MRCM, primary, SBA, single best answer, MRCM, intermediate, and RMSCM, OSCE. All right, membership or College of Emergency Medicine. So last time is MCAM, now is they add on the Royal College. So it sounds like an MRCP. Okay, so the requirement, you must pass the 3 paper, the MRChem Primary SBA, MRChem Intermediate SBA, and MRChem OSCE to be awarded with MRChem. And then after that, after 12 months of high special training, then you able to take the FRChem. In Malaysia, MRChem is not considered a specialist certificate yet. Okay. So the exam, MRChem Primary SBA has 180 questions, 6 time once attempt maximum 6 time. If more than that, you cannot continue pursue. And intermediate as but 90 plus 90 question, 2 papers, 2 hours each. MRChem OSCE is 18 station. And after that, after you awarded with MRChem award, then you can have at least 12 months specialist training to proceed to be eligible to continue for FRChem is single best answer and also FRChem OSCE. Okay, so it's no time limit. Once you take the MRChem and then you MRChem SBA, and after that, after this 12 months, then you can proceed to have special training for FRChem. Okay. Before you awarded with FRChem, there's also in between the SBA and OSCE, you have one paper that you need to, the critical appraisal and also the quality improvement project. It's kind of a dissertation. So you have a critical appraisal and also final quality improvement project. So that's you need to, before you can finish your FRChem award. So MRChem award, after you complete all the 3 papers. Why they say need MRChem? If because once you get the MRChem, you can be licensed and work in the UK. Because in order to get the FRChem, you need to work in the UK. That's what they said. It's 12 to 18 months working in UK. If I'm mistaken, still you cannot take the FRChem if you're not working in the UK. That's why. And at the same time, once you work there, you have better understanding of the system and also better passing rate. Okay. So there's a Malaysia requirement. At least you can see 1 month in 1 year of emergency, 2 months, 4 months, 4 months, 2 months pediatric critical care. So it's all total about 2 years at least for you to get the MRChem award. And then after that, once you get the MRChem award, you can inform the KKM that you have completed, and maybe after that they will help you for the posting. Okay, for 18 years in Malaysia, 18 months in Malaysia, 18 months in UK. Okay, this is basically how they do parallel pathway. So once at least you pass the first paper MRChem, then you can inform the unit kepakaran dan sub kepakaran perubatan in KKM, MOH, and then after that they will advise you, they will put you in the specific hospital that has the parallel pathway supervisor. Not all has supervisor, so there's a certain university hospital in Ministry of Health has the supervisor for FRChem, MRChem. So once you inform once and then you pass the MRChem OSCE, so you have MRChem award, you can inform the bahagian pengurusan latihan to have your hadiah latihan persekutuan for your sponsorship. Then that time they will plan for you to maybe sponsor or how they give you. I'm not sure because sometimes currently in fact HLP has many ways, whether you have total full coverage cuti bergaji penuh or you just cuti but gaji tak bergerak. So it's many and you need to work in UK to with a paid job. Okay, then after you completed FRChem, then you lapor diri to BPL lah for gazettement as a specialist lah. You can come back. So everything is still under discussion. They have I not sure whether there's someone has this scholarship yet. Okay, 18 months in Malaysia, 18 months in UK. Hopefully currently they say it's a paid job lah. I remember one of our PPUM they quit and joined they work in UK and currently finish complete FR camp. It's one of the team that do the quality improvement project. So yeah, in our university last time. Okay, so this ATLS, ALS, PLS, you can ultrasound, you can finish it up before you go there. Some of the training hospital for RCAM, and also once you complete your American OSCE awarded, you want to go for higher training, then you go this big hospital. So this is basically the difference. Look bit more cheaper, but if it's only once, if you fail, you need to pay multiple times. Okay. This still have dissertation for RCAM is critical pressure papers. Okay. Any question for this summary? For the Phu Leong?
For now, there's no questions, but we'd like to know about the subspecialty for masters in emergency medicine. But I think you'll be covering it after that.
Oh, okay, yeah, I'll cover it.
Yeah, yeah. So I think Doctor, we can proceed with the work-life balances. Yeah.
Okay, sure. So there's a very technical issue lah. There's because there's we still not sure because I think I still need to know about this more lah. All right, so the work-life balance in emergency, of course, you need to pray, and because you can't save all life, sometimes you just comfort care, okay? And this sometimes you do training. It's not only this, I say preparedness, and also it's enjoyable. You, if let's say LRT station, actually during the LRT disaster, the HKL and also UM or other few hospital has did the training in KL Central, and so they once they has that previous training, the disaster, they anticipate the disaster, so they can very quickly go to the site and also treat lah. Okay, and this is where we do the extra the disaster flood in Kubang Krian, where we help, and also part of the MOs did the CAC in the pusat the Taman Stadium Melawati in Shah Alam, where CAC, so is they work at PM shift or night shift. So in the morning, I think night shift. So in the morning, office hour 8 to 5, they do the volunteerism, and at night they work. So it's so great. They have the experience and also how the dedication. Very appreciate. So this is where the work-life balance. Last time, the emergency department did the ED run, emergency department domestic violence run. Okay, and luckily I got number 9. But this is a student category. Kalau if let's say international category, open category, maybe I'm not sure what number is. Okay. And I remember this during my master student, there's a medical society sports department invite us to play badminton, and yeah, I just sorry that I beat you all last time, not all. So thank you. Hopefully after pandemic we can play again. And this is a provincial where we have program keceriaan. So you can see our emergency has a lot of poster, history, very nice, ada water. Okay, there's a hari keceriaan lah. So sometimes you need to cycle and chill yourself. Okay, and gardening. Dr. Hafyzuddin like to gardening, so very impressed, very nice, very relaxing. And then sometimes we hiking during the non-MCO times. Okay. And last time we have family days. So Dr. Saleh is there, and as currently the TPK, right? And Prof also has bought everyday jogging, very healthy, sleep early, eat healthy, and jog regularly. Okay, that's a work-life balance. And I would like to thank want to share that the emergency department has got a second place as a best clinical department, for second place lah in faculty. Thank you very much to all the students and staff for that. And okay, for the perspective, as I said, there's a lot more that emergency physician needed. If you want to go overseas also, I think there's a lot more opportunity, especially the disaster. A lot of, I think, the doctor has because of the, I think in United States or Italy, because of the lack of PPE or lot of lack of equipment, they contracted COVID and sometimes they pass away because of that. So it's a disaster, silent disaster. It's not like atomic bomb or there's a disaster, a lot of things. For example, the man-made disaster, natural disaster. This kind of natural because of virus. Unless you say it's a warfare, it's not. Not sure yet. There's all theory there. So we follow WHO lah, WHO and KKM. So it's a natural disaster for disease. Okay, so MSQH, currently the MSQH is the Malaysian Safety Quality of Healthcare. So where if you accredited, it's good for the hospital, especially private. So currently, most likely the MSQH kind of a quality accreditation may require the all EPs. So, or if currently the EPs are not many in private, so there's a lot of opportunity in the private. A lot of EPs in private, they also more like administration because they know how to handle the staff supply and also the system. So that's how the important of the emergency physician skill. Okay, so the fellowship, you have critical care, kind of intensive care, and also, so it sounds like to bring the ICU to the emergency department, the critical care, because of the SS block or patient not able to go up, sometimes the critical care, the intubated patient stay in the emergency for a few days. So that's why we want to optimize the intensive or critical care. And the trauma, the full activation, you need to very quickly treat. In Sungai Buloh, they have the trauma life support team and the training place, and they have the damage control resuscitation suit, the DCR suit, which wins the MOH award lah for good innovation. So where this DCR damage control, you have you can do kind of a surgeon, but you need to be trained, thoracotomy or aggressive, more than what normal trauma team do lah. Okay. So last time we have a trauma surgeon in our hospital, but currently we don't have. So it's difficult to have that special treatment. All right. So pre-hospital disaster, yes, this is very interesting, and currently Dr. Hafiz, Dr. Aizu is pursuing. And pediatric emergency, hopefully one day I will join. I'll try my best to learn about the pediatric emergency. And toxicology, envenomation, the snake, toxicology, my friends think are going to join as well. Emergency cardiology, wilderness medicine, and many more, right? Some, like for example, United States, they said sport medicine is also emergency, sport emergency. So, but it's based on our recognition. Some nation has different recognition. Okay, conclusion, just be yourself. Think what you would like to do. Okay, sometimes follow your friends also okay, but just that make sure it's not totally blindly follow lah. Maybe you have a lot of choices, but think of the best for your patient, for yourself, for your families. Okay, and definitely enjoy your medical student life. So once you pass, you when you become houseman, you feel like you want to go to medical student. But when you finish housemanship, you become MO, you want to be houseman, because the more higher up, you more responsibility. So as a emergency physician, it's not only about, so starting is about the the disease, and after that treat the patient as a whole. Initially treat the disease, second phase treat the patient, and the third is control the department. So it's once you become higher, you need to control the staff, support system, all you need to optimize so that your medical officer, hospital officer, staff nurse, paramedic, all in sync with the best treatment. Okay. So emergency medicine or any other specialty is a marathon. So you need to work, study, rest, eat, pray, exercise, and then repeat. And always be grateful and sincere with yourself and your friends. Okay. Okay. Thank you for my friends. Some of my friends have become Muji Physio also, Dr. Khairul. Some gastroenterologists, some surgeon. Okay, my friends surgeon, and some neurologists, some cardiologists. Okay, so it's all now you're a medical student. You think what you like. Last time I tend to do MRCP, stay in United Kingdom or Ireland, but at the end, yeah, it's all takdir already. So you go home and work, treat your serve your country. Okay, but some of my friends work there already back to Malaysia. Some still there. So yeah, cannot know. And of course, family first, and discuss and make because currently my wife also continue doing master in anesthesiology, so need to have a support system. Luckily, my parents support a lot, and I also need to support as well. Yeah, so it's a team spirit, of course. Yeah. And I would like to say all the best with your study, all the medical students and everyone. And hopefully you guys join us in emergency medicine. I think maybe after 5 years, after you graduated, 2 years houseman. And during houseman, you can add more experience. And also after that, pursue in emergency, hopefully. Okay, stay safe and let vaccines. If you have any question, you can email me. That's my email. Thank you for your thank you for the attention. Thank you very much.
Thank you, Dr. Hafiz, for this elaborative and also so detailed kind of description of how emergency physician is like, and also the pathway, and how a emergency physician actually has the work-life balance, and how he's totally enjoying the emergency physician pathway. So yeah, doctor, can really see you are really passionate in presenting this teaching presenting this pathway to all of us lah. So yeah, Dr. Hafiz, you can see down here there's a few comments in Facebook. So Alia Zabri, is it your doctor's friend?
Yeah, there's a currently youngest emergency physician, the one that I showed the first photos. Thank you, Dr.
So
Alia.
nice. There's another question from Dr. Muhammad. I think Mohd Hafyzuddin decided. Yeah, is it a doctor? How does emergency physician contribute during this pandemic? Do they just treat patient in ED, or do they play a bigger role? Yeah, doctor, do you mind to answer this question?
Dr. Hafyzuddin is my friend. Is also emergency physician. So of course, we give more than pandemic, we play a bigger role, because if there's as a gatekeeper of the hospital, and also the currently the pandemic is responsible is a public health specialty. There's a primary team, Tan Sri DG. Then after that is a public health. But below that, of course, emergency physician contribute not only the strategy. It's because it's a disaster, so we need to open up our hospital. We prepare. We want to prevent the outbreak in our emergency department, and also if we wrongly triage, maybe the infection can go to those upstairs outbreak. So definitely we have done our best like screening questions, RTK, PCR, and then we treat appropriately. And of course, once if let's say there's if the hospital need some backup, we of course we are like the vaccine people. We are the first initial person to see the patient. So definitely we are play bigger role. We can deploy anywhere as well. Yep. And the pre-hospital also, we have increased our PPE. The pre-hospital, we send the patient to the Sungai Buloh. We take the patient from the rumah. So yeah, the emergency definitely play a bigger role.
Especially when all the news headlines, we see frontliners like emergency physicians dealing with
the frontliner.
The front line. So definitely, I also think that emergency physicians actually play a huge role in helping this pandemic. They are the frontliners of the frontliners. So
yeah,
doctor,
we assume all has a COVID antibody otherwise.
True. So, Doctor, there's another question from Kate Young about how do you ensure optimum level of he didn't finish the question, but I think how do you ensure the optimum level of energy during your emergency physician shift?
Oh, Dr. Cat.
Oh, it's Doctor.
Another
Doctor.
senior lecturer.
Oh, okay.
Optimum level, yeah. I think, of course, need a lot of coffee and optimal level of the energy and focus in emergency, I guess. So I think one, coffee, enough sleep, enough of course you need to have enough sleep, enough rest, and also eat well, and coffee. So if let's say you cannot stress too much, because if you stress, your mental will be blocked and you cannot focus. And there's a study, I think, if you stress and the heart rate become more than 140, 50, you can suddenly lost bowel motion. In fact, I think that's where the importance of the simulation. If let's say you the military, they do training 120%, 130% optimum, because once they're in stress, the performance level will be reduced. So always training in the stressful environment sometimes improve your during the real, just to for the because of our condition, emergency is very sometimes can be chaotic, uncontrolled, and stressful. Yeah, but that's how you want to control and be the leadership, because one of the quality of the emergency visit is the leadership quality. For example, ACLS is the spirit of the leadership is there, so you can control. If I remember during the disaster course, if let's say one thing happen, if you not control the situation, so the public will control, so that's more worse. So of course you need to control the situation, and after that do the appropriate thing.
Yeah, definitely there's a lot of aspects in like how to ensure the optimum energy level and also treatment level for the when you're functioning as an emergency physician. As like what doctor said, so many things to learn, and then there's the cognitive overload, and then somehow you need to know a lot of things, you have to do a lot of things. So it's like, how do we ensure the optimal level, especially when we're in a shift, when they are working so many hours, so many patients all together. So definitely there's a lot of factors that is involved, like what doctor said, coffee, and then teamwork as well, doctor. Teamwork, algorithm, pattern recognition, like what doctor said. A lot of things that can be combined, so that there's an optimal level or even a better level functioning as an emergency physician. So yeah, there's another question for doctor, which is from Aiman Ibad. So there's one question is, he's asking how many candidates for the MED program per session. Yep.
Okay. Oh, sorry. Before that, MED per session, yeah. Okay. Before that, I would like to add on the optimum level. I just remember the master
Sure.
in is emergency is triaging. So once you triage, whether it's critical, non-critical, urgent, not urgent, life-threatening, semi red, yellow, green. So hopefully you can sort it out and focus on what's the important thing. Just like your life, if you know your work today, what's your red, what's your green, what's your yellow, and if black, so you can delete. Mean black is dead. So if nothing important, so it become black. Okay, so the question of the master emergency medicine, how many candidate in MED?
How many
So
candidates?
the statistic number is about 200 plus that apply, 200 to 300 if not mistaken. But the one that we can intake is about 70 to 80. So that's distributed among the 3 or 4 university under University Malaya, UKM, USM. So about 2 to 300 apply. About 70 to 80 candidate managed to get it.
I see.
So in university, about 20 students, about 20. Yeah.
Yeah, Doctor, just to ask you, per session is per the session admission for the university, right? Master's program. So how long is the duration between the program?
Duration?
Yeah.
It's about 4 years. I mean, every year they take. Every year there's a MEDEX for the exam. Yeah, and then interview every year as well.
Interview, okay.
And then after that, every year is about 300 or 200 applicants. They will admit and take students about 70 to 80 every year, yearly. Just that the pandemic last year, supposedly normally the master start on June, but last year the June intake is not taken and it started in December. December. So it's have been shipped 6 months. The COVID has changed all the master student training, delay about 6 months. So everything the first year has started. So there's no intake on June. Is the June has become second semester. So it's a 1 year 2 semester. So now it's the intake is next intake will be December. So but they already interview and do exam on March, February like that. Yeah.
I see. Doctor, there's another question for you from Dr. I think Masita Hassan.
Okay.
What personality one should have to join emergency department? Like aside from the traits, like how should one be? Not to say behave, but like how is their personality like, so that they are more inclined to joining the emergency department?
They have to be fast paced and ready to go lah. Usually is, as I say, it's a standby mode, always standby mode in emergency department. So you need to have a focus and attention very high level. So once you go there, the personality is you should be always standby mode, always prepared. Preparedness, yeah.
I see. There's another add-on question from Mohaimin Nora Azhar is that one personality that Dr. Ting is really not suitable for emergency medicine.
Dr. Mohaimin is HOD of the emergency. Oh man.
Hi doctor. Hi prof.
Not suitable, yeah?
Yeah.
Not suitable is if let's say they not a team player lah, because as I said, the emergency need a teamwork, because you can it's a big place, it's a lot of patient undifferentiated. You cannot solely do everything. So if let's say you diagnose and then you ask the nurse to do this, you ask paramedic to do this, and then of course you don't know things, you malu to ask or you don't cooperate with the other department because you kind of center the if you can't help your patient to go to the different wards, you cannot communicate. Yeah, so it's a communication is important. It's always say the communication. So if you're not a team player and also has poor communication, is difficult because it's the core. Because every day you about communicate with the patient, and if a lot of problem happen when you miscommunication with the patient or family, that's how become problem later on.
Agree, because for emergency medicine, I think really communication is the way to go. You need to communicate with the nurse, the paramedics, and then the patients. And then if you refer to like maybe surgery, orthopedic surgery, maybe ICU, and other like if you want to ward the patient and so on, everything needs communication. And as well as when we communicate through like any disaster response control, something. And since like emergency physician, like this kind of profession actually is a team of specialists, like what Doctor said. So definitely teamwork is really important in emergency medicine. Yeah.
Yeah, definitely.
So, Doctor, I think one last question, or like the second last question before we end the session. So it's from Raymond. So good evening, Dr. Hafiz. Besides treating patients on the front line, how can emergency physicians play a role in health policy development in Malaysia, especially to raise community awareness on seeking care promptly for medical and also surgical emergencies? Yeah, I think it's more towards like the public health.
Play roles in health policy, okay, especially to. So this actually the health promotion is it can be individual or it can be a society. So if you have a society, I think a MyRes, the Resuscitation Society, or Malaysian College of Emergency Physician, it's a lot of awareness, increased awareness, but with the free webinar, free talk, especially for let's say I did one talk. The wartawan asked me about the CPR in the TV Al Hijrah, but I think 2-3 minutes is discussed about important of starting the CPR. So that's one of the thing that, because if you have no bystander CPR, no one CPR, when you saw someone collapse and brought to the hospital, the mobility, the risk of to get a RSC is very, very minimal. So that's where you want to educate. For example, for medical or surgical, that's a really need to have a lot of mainstream player. I think health policy, the policy of disaster, pandemic, I think there's a lot of emergency physician involved, because let's say there's overcrowding. There's overcrowding always in the emergency department. So they need to know how to decongest, how to search capacity. For example, let's say they need to ask for the military, and also the in fact in the COVID, the PKR, the pusat quarantine in MEDSOC, the emergency physician did the triaging, the ultrasound to check whether patient admission or not. So the health policy development, that usually is they need to do the SOP. I think there's part of the, because development policy development, there's include the emergency physician, the medical department, surgical, everything. Everyone need to discuss the health policy. It's not only EP. It's always taken by public health, but EP is part of it. Family medicine is part of it. Surgical, medical, pediatric, ONG, all teams need to. But for specific for emergency physician, we have like public health is EMS, like the emergency medicine service.
Emergency medical
is
service.
Ambulance. Yeah, emergency trauma service is ambulance service, pre-hospital. So that's because pre-hospital is near to the patient, near to the community. So that's where the policy is very important. For example, whether you need helicopter, you need ambulance, you need boats. So pre-hospital is and disaster is near to the patient, near the house.
thank you for the elaborate explanation for Raymond's question. Yeah, I think for emergency physicians, each specialty has their own role to play in health policy development. So for emergency physicians, they are more towards like reaching out to the public, like um, pre-hospital care and helicopter and so on, like
Yeah,
the
BLS
emergency
or
medical searches.
CPR, we always need to train the citizen
Yeah,
for the
train the
basic life
citizens.
support.
So
Yeah.
yeah. So yeah, thank you, Dr. Hafiz, for the answer. So right now, we are approaching to the end of the session. So Dr. Hafiz, do you have any last words for medical students who are aspiring to be emergency physicians?
Okay, so always happy when the student come to the emergency because that's where I can instill the love of the emergency to them. So once you go to 3.2 usually, so yeah, get a lot of times with us extra class maybe or ask questions because definitely the emergency medicine is still evolving. A lot of new discovery or new methods, and also the treatment always changes. This SOP, so always ask and um, enjoy your training and work hard in emergency lah, and other study as well. But definitely during the posting, so yeah, always be around in emergency.
Okay, yeah. So thank you, Dr. Hafiz, for actually accepting our invitation to give this great talk. So we know a lot about emergency physicians and as well as how to get in to be part of the team as well. So again, thank you, Dr. Hafiz, for joining us today at night. So yeah, so thank you a lot, Doctor.
My pleasure. Thank you very much. Have a good
Thank
weekend
you.
and stay safe.
So for the audience, remember to fill in the feedback form that was actually stand in the Facebook chat box. Yeah, so through the feedback, we can actually improve better. So you can also give in your input on like what kind of other specialties that you want to see and so on.